Hello everyone, I'm Dr. Afrin Rajoy, and today we are going to talk about the foundations of medical family therapy, history, and overview. So basically we are going to respond to this big question that what is medical family therapy? Before anything, let's talk about the pioneers of the field, medical family therapy. So the pioneers include some of the family therapists that most of us, we know them, right? You see the names on the screen. And let's talk about some of, their work just very briefly as an example. So, for example, Bateson led the schizophrenia project back in, Palo Alto, California, and he discovered the concepts of homeostasis and double blind. Um, he didn't believe that families were the cause of actually schizophrenia, but rather family communication patterns may lead people, with this diagnosis. And the reason behind that is because of that communication patterns, they have trouble interpreting messages and, determining what people really mean. Another example is Whittaker, and Whittaker became one of the first to break from psychiatric tradition and experiment with family treatment. He took special interest in working with families with a member diagnosed with, again, like schizophrenia. And then another example is Bowen, and we all know Bowen was a psychiatrist who specialized in schizophrenia. And back then he developed this project that he hospitalized the whole family with schizophrenic members, and this whole project led to discovering a concept which now we call triangulation, right? Or we know Bowen actually called that, but like we know that triangulation concept. And at the end of the day, like he worked with the smaller subsystems and eventually with individuals, but he always had this systemic perspective in his work. Then we have Minuchin, and Minuchin began his career as a family therapist back in 60s, and he and his colleagues used to apply family systems theory to medical problems. And he was the first person who developed and coined the term psychosomatic families. As you probably recall, psychosomatic issues are about physical manifestation of psychosocial distress. And he discovered that we have families that we see those psychosomatic issues in the system of the family, right? And different studies throughout all these years, and in his time supported this concept of or this term of psychosomatic families. So if we have those family therapists who with the different things that they have done or they did in that time, they have contributed to the field of medical family therapy. But then back in 90s, Susan McDaniel, Hepworth, and Doherty, they kind of like developed and coined the term medical family therapy, and they wrote the first book about medical family therapy. Later on, other scientists and scholars such as John Ronald, Jennifer Hodgson, Angela Lamson, Ty Mendenhall, all the different names that, again, like you see on the screen, they contributed to the field of medical family therapy in very meaningful ways. Jennifer Hodgson and Angela Lamson were the first people who developed a Ph.D. program in medical family therapy in the US and in the world. So what we are talking about here today and what we have about medical family therapy today, it's really because of all these names that you see on this screen and all the beautiful and meaningful ways that they have contributed to the field. The first kind of like big question that we have here is what is medical family therapy, right? And there are not one way to talk about it. There are many different ways to talk about it. What I'm going to do today is I'm going to start from this slide, and I'm going to start the conversation about it, and then I'm kind of like going to expand the conversation by the different things that we can add to it. So one kind of like general response to what is medical family therapy is that medical family therapy is about these concepts that you see in this slide, is about health, loss, trauma, death in the context of a family, and then it's about the interaction and kind of like interface of this system and these concepts with various systems that we have, such as military, such as schools, all the different systems that we have. So in other words, we want to understand health, loss, trauma, death in the context of family, in that kind of like system, and also what does that mean, or what do they mean in interaction, or in when they have this interface with various systems such as military, schools, or the different systems that we have in society. So another way of looking at it is that back in 80s and 90s, people such as Susan McDaniel, Hepworthy Doherty, they really had this conversation that we should have a way of, addressing the intersection of the needs of healthcare systems, right? And when we are talking about this intersection, we are talking about healthcare system needs, we are talking about patients' needs, and we are talking about family system needs, right? And then one way of, addressing all these different needs is having this term medical family therapy, and addressing all these different layers and systems in this field in medical family therapy. So medical family therapy is here so we can have a holistic approach, kind of like comprehensive approach in our healthcare system. So a basic premise of medical family therapy is that there are no psychosocial problems without biological features, and there are no biomedical problems without psychosocial features. It took us so many years to realize that there is body attached to the mind and there is mind attached to the body, right? And if we want to have this whole person perspective and holistic approach, we need to have a field with its own interventions, with its own competencies and kind of like features, so we can think about and look at things from a different perspective. For a while there was this debate about medical family therapy, and if it's a field, if it's intervention, if it's approach, if it's a specialization, what is it, right? And then at the end of the day, people realize that scientists, they realize that medical family therapy is very comprehensive, and it has its own interventions, its own core competencies, its own techniques, and all these different theories that it uses. And because of that, it's a field, it's not a specialization, it's not an approach, it's a field with all these different features that we are going to talk about more. So medical family therapy highlights collaboration and inclusion, and it's going to focus on agency and communion, and in the next slides we are going to talk about how. In other words, medical family therapy is here so we can understand the different layers of relationships that are necessary to address health, illness, and recovery. We started our conversation with this question, that what is medical family therapy? And so far, we talked about the fact that medical family therapy provides comprehensive patient care by conceptualizing illness and symptoms from a systemic perspective. So we have different theories and framework that we use in medical family therapy, and actually medical family therapy is rooted in principles of general systems theory and links the biomedical with the psychosocial and spiritual dimension of health. The other theory that we are going to talk about in a second framework, it's CJ Peck's 3 or 4 worldview framework that includes operational, clinical, financial, and training aspects of healthcare. So we are going to talk about all these different frameworks and theory briefly in the next slides. In case you are not familiar with general systems theory, in systems theory, we explore how parts work within a larger system and how changes in, within, and between parts impact other parts of the system. If you ever heard of the word gestalt, in gestalt therapy, they believe that the whole is beyond the sum of the parts. And if you look at the picture that we have here, the two pictures, the parts actually, like the sum of them, the last picture that we have, the results kind of like it's beyond the sum of the part. So what does that mean in terms of family therapy and seeing clients and working with patients and families? So it means that when we are working with people, we consider them in relation with others. In other words, we consider contextual factors, and we consider all the different stories and individuals in different contexts and different systems that they are part of, not in isolation. And that is a very different kind of like perspective and approach in comparison to individual perspective. The other framework that we use in medical family therapy is biopsychosocial spiritual framework. BPSS is the framework that considers or suggests that our well-being or health has four dimensions: biological dimension, psychological dimension, social, and spiritual dimension. And our well-being or health is a kind of like balance of all these different aspects. One thing about a spirituality, because it's a common mistake sometimes, a spirituality is not just about religion. It's about meaning-making systems. So meaning-making systems for different people, different patients may look like differently, right? So for some people it's religion, it's organized faith or religion. For some people it's karma. For some people it's energy. For some people it's what other people may call quote-unquote superstition, right? As long as the meaning-making systems that people and patients and families have, as long as they are like working for them and there's no harm for other people, we respect them, and we really try to promote that aspect of their life in working with them in the healthcare system. So the BPSS framework, usually people, when they hear about it and they learn about it, it makes sense. So they're like, duh, yeah, it makes sense. But the challenge is that most of the time, or a lot of times, we do not consider this framework. We do not have this way of thinking in working with patients and families in our healthcare systems, right? So you can ask yourself, how often do you ask questions about all these different dimensions when you're working with clients or patients, right? So when we are working with depression, how often do we ask questions about, like, if there was a lab test, if there is any like physical symptom, anything that we should know about the biological world, right? The same thing about the spiritual world, or just considering the balance between these four dimensions. So in medical family therapy, we really try to promote this framework and this way of thinking in working with healthcare system and patients and families in the assessment process, interventions that we are going to have, and generally like working with the healthcare systems in different settings. Another framework that we use in medical family therapy is CJ Peek's four worldview framework. So this framework suggests that healthcare systems, they have four different worlds or dimensions: clinical world, operational world, financial world, and training. Clinical world is about what we do in a healthcare system. So all the strategies that we use, the things that we do, the interventions, and for example, how inclusive we are in our services, right? All those different things. Operational world is about how we do what we do, right? So it's about the policies that we have and workflow in a healthcare system. Financial world is about billing, coding, and reimbursement, and again like different policies that we have in that sense. And training is about training about all these different aspects, right? So here's the thing: CJ Peek believes that a healthcare system could only be successful if there's a balance between all these different worlds, right? So if it happens that we forget about one of these aspects and we do not focus on them, do not promote them, then there's a chance that that healthcare system will not be successful. And again, like as medical family therapists, for us in the different roles that we will have as a therapist, as a medical family therapist, as a researcher, leader, director, supervisor, all those different roles that we may have in the future, it's really important for us to be mindful of this framework and use it in our work. Again, like if our work is clinical or research based or leadership based, it's really important to work on these different worlds and also highlight and promote collaboration when we are working with these different aspects. A lot of times when we are talking about medical family therapy, we talk about integrated healthcare systems as well. Integrated care is an effort to better match or blend clinical services to the realities that patients and their clinicians face daily. As we mentioned earlier, it took us some time to realize that there is body attached to the mind and there is mind attached to the body. And because of that comprehensive and holistic approach and the fact that we need to have like interdisciplinary kind of like team, right? We need to have collaboration. That because of all those different things, integrated care makes a lot of sense, right? And this lecture is just kind of like an introduction. So we're going to talk about integrated care and, integrated healthcare systems, the different levels of that more in the future lectures and textbooks. But for now, just, become familiar with the definition of integrated care and why do we have this, emphasis on it. I'm not going to talk about integrated healthcare systems and the different levels that they have in full detail right now, because this is a topic for another lecture and, other weeks. But for now, I just want you to become familiar with the fact that integrated care and healthcare systems, they can have different levels. So some people, they talk about it as it's like it has 5 levels, and then some people, they talk about it as 6 levels. Basically, they are very similar. And at the end of the day, the important part is that sometimes they are about coordinated help, which means like people, they need to go to different facilities to get different services. Sometimes we are talking about co-located facilities. So they are in the same facility, but they have different offices, and people, they need to go to the same building, to the same facility, but different offices to get services. And sometimes they're fully integrated, meaning they're in the same facility, and even like the office space could be shared. That's again like the very general description of that. Of course, that there are differences in terms of how they use the systems, in terms of communication, collaboration, that culture of team-based culture, and understanding each other's roles and respect and appreciate each other's, and that goal and passion to promote teamwork and collaboration in a system. We will talk about it later in more detail. Two main goals of medical family therapy include agency and communion, and we are going to talk about what we mean by agency and communion, and we're going to talk about one example about that. Agency is about autonomy and power regarding patients' healthcare, and we try to engage patients as experts in their own illness experience and help them develop their agency. So basically, as medical family therapists, one of the main goals that we have, again, in different roles that we may have, research, clinical work, leadership, all those different roles, we want to promote agency for patients and families to be in charge of making decisions for their own health and illness. Communion is about the closeness and relationship quality among patients, their families, and other support system. It's about ensuring that patients do not suffer alone throughout their illness. So we all know from personal experience that when you are going through illness, recovery, trauma, all those different things, it's just so hard, and it's a challenging experience, let alone that you feel like you're alone in that experience. And as medical family therapy, we are here to make sure that patients and families, they don't feel like that. They feel like they matter and they are not alone, and they have a support system in their experience. Here I'm going to share one personal example that I have from my own professional experience working with patients and families. And hopefully in this example, we cover some of the things that we have talked so far. So some years ago, I used to work at this integrated healthcare system back in North Carolina. And one day, the primary physician or primary care professional came and told me that there's this patient, and the patient is not compliant, and he doesn't take his medication. He has high blood pressure, and the physician asked me to go and talk with the patient and make him use the medication, because his situation and the high blood pressure is just so serious, and if he doesn't take the medication, something bad is going to happen. So I went to the room and I started the conversation after introducing myself and stuff like that. I started conversation with this statement that no one here, I want to make sure that you know that no one here is going to make you do something that you don't want to, right? So you are the expert of your life and your illness story, and you are going to make that decision, right? And then I started, making the rapport and the alliance with the patient, and then I asked him kind of like kindly that I've heard like about the medication and the high blood pressure. Could you please help me understand why you're not taking the medication? And the patient started talking about his faith and the fact that he's going to pray, and he thinks that praying is going to help him, right? So again, like I asked the patient, could you please help me understand how praying is not aligned with, you can not pray at the same time that you are using the medication. And again, he started talking about his belief system. Again, just in parentheses, be very mindful that in asking all these questions, you really need to be mindful of your tone, your body language, because you can ask the same questions and it seems like you're mocking the patient, right? So just genuinely be there, be curious, and have this sense of unknowing and, kind of like wanting to know the patient from the patient, not from your assumptions. So we had this conversation for 20 or 30 minutes, and then at the end of our conversation, the patient told me that, you know what, you're right. I feel like I have this blessing, the fact that I'm here on this planet, I have this blessing, and I have to kind of like take care of that, and that is my responsibility. So let me go and pray for another month, and then if it doesn't get better, then I will come back and I use the medication, right? The interesting part was that at the end of the conversation, the patient told me, thank you so much for listening to me. A lot of times when I go to a doctor or healthcare systems, especially because of, the socioeconomic status of the patient, I just feel like they just want to get rid of me, and they ask all these questions, they don't listen to me. And here my experience was different. I feel like I matter, and my belief, what I say, matters. So thank you so much for this experience. I just feel so good that you listen to me and I'm important for you. And this is what, when we are talking about agency and communion, this is what we meant by that, right? Then I came out of the room, I went and talked with the physician, and I explained the situation, the BPSS framework, the spirituality meaning making system. And this is the part that we say medical family therapy is all about, that collaboration, right? Collaboration between the physician, you yourself as a medical family therapist, the patient, the families. So sometimes we are there to kind of like facilitate these conversations. And then, I went back to the room and, talked with the patient about, the next visit and everything. So this is just one example of how medical family therapy works, and how the different skills that we have in diversity, in biopsychosocial spiritual framework, in systems theory, and ethics, all these different things, the core competency that we are going to talk about in a second, how all of those things, they are really important, and we really need to fully grasp them so we can use them in our daily experience with patients and families. The other concept that is really important in medical family therapy is cultural humility, right? So cultural humility is this lifelong journey of practicing being humble, flexible, and have a patient-oriented approach, right? For being culturally humble, you need to be very mindful of your own social location factors, right? So for example, the fact that I'm a female, I'm white, I'm young, I'm educated, I'm immigrant, all these different things. How are they going to affect the relationship or the interaction that I'm going to have with patients, right? The biases that I have, right? The assumptions that I have, and the stories, the kind of baggage or luggage that I carry with myself to the room, or in working with patients in my research. So practicing cultural humility is really important. Like other fields of mental health. It's also very important in medical family therapy. And again, in every conversation that we have, every course that you pass, and any sort of experience that you have in medical family therapy, this culture of humility should be really highlighted. Next thing is medical family therapy core competencies, which includes six main core competency systems: biological, psychological, social, and spiritual framework, collaboration, leadership, ethics, and diversity. You can see the definition of them on this slide. There is this whole PDF file on the MFT website, which my colleagues and the pioneers of medical family therapy, they kindly and wisely provided for us. But again, like, we're going to talk about this in the future lectures more and more, but um, in medical family therapy, in again, like any course that you will pass, any kind of experience, supervision, we are always talking about these different core competencies, and we are always looking for ways to improve them and work on them in our experiences. If you are interested in medical family therapy, which if you are listening or watching this lecture, I assume that you are, then there are different options in terms of the next step. So graduate education, internship and fellowship opportunities, and working on competencies. In terms of graduate education, we have, to my knowledge, two Ph.D. programs in the US and in the whole world on medical family therapy. Excuse me. And then we have all these other master's program that they either have a path, focus, a specialization track, or a certificate program in medical family therapy. Then we have internship and fellowship opportunities, and again, like in all of these experiences, you work on core competencies of medical family therapy. So we started with this general question, that what is medical family therapy, and then we talked about the definition of medical family therapy, what medical family therapy is about, the different theories that we use in medical family therapy, the goals of medical family therapy, culture, humility in medical family therapy, core competencies in medical family therapy. And then if you're interested in medical family therapy, what is the next step? Then the next question sometimes, or the next thing that we should know about medical family therapy is that, okay, I go and I get my education, then what kind of roles can I have as a medical family therapist? So as I mentioned in the beginning, we can have different roles in clinical settings. You can be a therapist. We can have leadership roles. So directors in hospitals or behavioral health section of hospitals, or medical schools. Then we can have research-based positions, obviously, and we can have supervisory roles in different settings. So all those different things, they can be very exciting, and also they can be very, or somewhat different from what you have in mind. For example, I know someone who is the director of employee well-being at a hospital, and her role is very different from the kind of like traditional expectation that we have about employee well-being kind of like section or department. So her whole responsibility is to make sure that the physicians and medical professions in that hospital, the rate of burnout and all that stuff that we know from research and from experience, based on what we know from research and experience, they don't experience burnout and fatigue as much as they usually or they often do. So she has all these different interesting programs and surveys and different things that she does, and based on her education in medical family therapy, she makes sure that she's taking care of the employee well-being, which is, from my perspective, very interesting. Where can we work? So the different work settings that medical family therapy can work at include hospitals, outpatient facilities, universities, college, private practice, nonprofit and profit agencies, and research institute. So at the end of the day, we as medical family therapists, in different roles that we have and then in different settings that we may work at, we want to improve population health, we want to improve patient and family experience, and we want to reduce the cost of healthcare system. Thank you for watching and for listening. And if you have any reflections or questions, please let me know so we can talk about it more.